Good morning, everyone. I'm Donna Jornsay. I'm a nurse practitioner, diabetes educator with a certification in advanced diabetes management. And I'm here this morning at the MEDS conference in Orlando, Florida, to talk with you about reproductive concerns for people living with diabetes. So my first point that I'd like to make to you is that there's a different genetic risk if you're a man with type 1 diabetes versus a woman with type 1 diabetes. The male chromosome carries the genetic marker for type 1. So if you're a father thinking about having children or a man thinking about having children, then your genetic risk of your offspring having type 1 diabetes also is 5 to 6%. That's a lot higher than it is for women, where it's only 1 to 2% because that male chromosome is carrying the genetic marker for type 1. However, if you were a woman with type 1 diabetes and you didn't have good control of your diabetes during pregnancy, that could create an additional environmental risk in addition to the pre-existing genetic risk. The second point I would like to make is that if you're a woman without diabetes, but you're overweight or obese, your primary care providers would really want to do an A1C in you to determine that you don't have any glucose intolerance before you conceive. Because we know the risk in women who are overweight or obese for type 2 diabetes is higher than it is if you were at normal weight. And if you have unrecognized diabetes and you become pregnant, you would increase that risk of having a baby with a birth defect if the blood sugars were higher than normal in those first 8 weeks of conception. And the last point that I would like to make is for women with known diabetes, it is incredibly important that they totally normalize their glucose prior to conception because of that risk for malformations. It's typically the first 7 to 8 weeks of pregnancy, which is actually 9 to 10 weeks because we date pregnancy from the last missed period. So those women, we really need that A1C to be 6% or less, ideally. Up to 6.5%, there's no increased risk for a malformation. But malformations can be lethal. So we want to know as primary care providers that we've done everything to normalize that risk for our patients by advising them to normalize that A1C value prior to conception. What we see in women with high blood sugars during that period of conception is we see their offspring have midline defects. So those tend to be cardiac defects are the most common, transposition of the great vessels being the most common, but also spina bifida, caudal regression syndrome, anencephaly, so very serious defects that are sometimes incompatible with life. So please, if you're the primary care provider for a woman with pre-existing diabetes, encourage her to do everything possible. Getting herself into a diabetes and pregnancy program if they exist in your area, but doing whatever is possible to normalize blood glucose control prior to conception. Thank you.